Good afternoon, colleagues and senior doctors. The topic that is going to be presented now is management of stroke in the elderly. This is a very important topic. As we all know, the presentation of stroke in the elderly can be, initial presentation could be atypical, it could be missed. The treatment involves a lot of challenges, a lot of decision making. For this, I call upon Dr. Chinmoy.
To speak on this important topic, we have an eminent speaker, Dr. Chinmoy Kumar. Sir is sir is a senior consultant in geriatric medicine at multiple hospitals, Calcutta, and sir is the ex-chairman of Geriatric Society West Bengal branch. Sir is also an examiner in the MRCP PACES exam, and sir has various publications in various journals and various textbooks. Over to you, sir.
Good afternoon, everyone. Respected chairpersons, my seniors, and dignified delegates. At first, I must thank my friend Sajesh and the organizing committee for GSICON 2024 for giving me this opportunity to present before this August gathering the management of stroke in elderly. As you all understand that this is a very huge topic and it is very difficult to cover it within 20 minutes. But that's why I have to skip a few slides and I am actually beg my apology in advance that you may have to give me the lifeline for a little longer than 20 minutes maybe, but I will try my best. As you all know that stroke and transient ischemic attack both are acute onset neurological disorders of vascular origin. In case of TIA, the symptoms and signs last for less than 24 hours, and in case of stroke, it lasts for more than 24 hours or lead to death. As both of them are of vascular origin, let's have a quick look at the vascular supply of the brain. As we all know that there are two internal carotid arteries which forms the anterior circulation with its all branches, and two vertebral arteries forming the basilar artery, then its branches forming the posterior circulation. The yellow and the blue bit represents the anterior circulation and the red bit represents the posterior circulation. I don't have time to go through this one. The vascular territory and stroke syndromes you all know of. There's a brief discussion on leading 10 causes of stroke. The topmost cause is the elevated high blood pressure, which contributes about 56% of the stroke burden in the world. Then high body mass index, 24%. Then high blood sugar, about 20%. Air pollution, 20%. Smoking, about 18%. Poor, unhealthy diet, about 31%, high cholesterol, 10%, and so on. The incidence of stroke, about 12.2 million new cases of stroke happening every year. That means one stroke every 3 seconds happening in some part of the globe. And about 101 million people worldwide are living with stroke aftermath, that is the prevalence, and that number has increased from 54 to 101, almost doubled in last 30 years. So according to current figure, about 1 in 4 people will have a stroke in the lifetime. So you know as many people here in this auditorium now, 1 in 4, so 1/4 will have a stroke in the lifetime. That's a huge burden. Interestingly, up to 80% of strokes and heart attack happens in people with low and moderate CVD absolute risk. So that's a very interesting point. This is the green and the yellow zone. That represents about 80% of heart attacks and stroke. So they should be targeted, not only the high risk one. Then about 89% of the global stroke deaths and disability combined reside in the low to middle income countries. So out of these 101 million stroke prevalence, 58 million in Asia and about 15 million in Africa and over 15 million in North and South America combined, and Europe about 12.6 million. According to 2017 statistics, the total estimated worldwide stroke cost was 451 billion, which was about 0.36% of the global GDP. Annual stroke, the age distribution of stroke, about less than 50 years old, 16%, 50 to 70 years, 46%, and more than 70 years, about 38%. The global, the sex distribution of all strokes globally, female, slightly female preponderant, 47 is to 53%. Ischemic stroke counts for about 62%, hemorrhagic stroke about 28%, and subarachnoid hemorrhage about 10% of all strokes. The previous data, if you see in most of the textbook, that it says 80 to 85% are ischemic strokes, 10% hemorrhagic stroke, 5% subarachnoid hemorrhage. But those are the very early stroke data coming from United Kingdom, Europe, and America. But this is the global fact. Annual stroke mortality in case of ischemic stroke, it's up to 40% annual mortality. In case of intercerebral hemorrhage, it's up to 60%, and in subarachnoid hemorrhage, it's about 60%. In recent times, stroke data are emerging from the developing countries, including India, but the reliable, authentic data is a scarcity still. So ischemic stroke, and it actually contributes, in India, it is the Indian data. Ischemic stroke contributes about 65 to 84% in different studies, and hemorrhagic stroke 11 to 35%. Here is male preponderance. About 65% of the cases are male in Indian scenario. Annual incidence 1.25 million, annual prevalence 9.4 million, which more than doubled since last 30 years. 1 month mortality is 18 to 42%. Compared to the Western data or the developed country data, it is significantly elevated. India contributes around 10% of the world stroke burden. So overall, globally, 2/3 of all strokes are ischemic strokes, and about 3/4 of all stroke victims are more than 60 years of age. Some specific issues with the elderly. As we all know, that elderly has got cognitive problem and sensory impairment. They have multiple comorbidities, including previous strokes. So assessing them is a difficult job. They have higher incidence of stroke mimics. Then personalized care planning and goal setting may be different in the frail elderly. Evidence-based guidelines may not be applicable to the frail elderly. Invasive and interventional therapy may not be so useful, rather may lead to catastrophic complications. So that should be kept in mind before planning treatment for the elderly. Now coming to ischemic strokes, so the immediate underlying etiology in this case, 25% are cardioembolic, and then about 25% are in situ thrombosis, and then 50% artery-to-artery embolization. I'll mention briefly about the TOAST classification of ischemic stroke. This is very, very important in this era of endovascular thrombectomy and endovascular thrombolysis therapy. This is based on the size of the artery with possible underlying cause. So large vessel atherosclerosis, small artery occlusion, cardioembolic, stroke of other determined cause, and stroke of undetermined cause. Then pathophysiology of ischemic stroke, the normal blood flow of brain is more than 50 ml per 100 gram per minute. So with gradual decrease in blood supply, there is progressive loss of cell function, and when it goes below 10, it leads to infarction or cell death. We all know about this concept of ischemic penumbra. So their central core is the dead necrosed tissue surrounded by an area of salvageable brain tissue with variable perfusion, and this is the target for perfusion therapy, reperfusion therapy. Now coming to the hemorrhagic strokes, mostly due to the rupture of deep-seated aneurysm, which is a consequence of hypertensive vascular disease. Then coming to the lobar hemorrhage, it is a special type of intracerebral hemorrhage. These are situated in the peripheral cortical part of the brain, usually affect the younger person who are normotensive. And this is due to rupture of saccular aneurysm or AVM. They should have a early CT perfusion or a MR angiography to detect them, and it should be surgically treated. Then surgical evacuation is beneficial in cases of cerebellar hematomas and only rarely in supratentorial or cerebral hematomas. Now coming to subarachnoid hemorrhage, we all know the most common cause is aneurysm, 80%, and AP malformation, 5%. Most of the aneurysms are in the anterior circulation. We all know about the clinical features of subarachnoid hemorrhage. Urgent CT scan helps us to diagnose. After 12 hours, we can do a CSF study for xanthochromia, and 4-vessel angiogram may be necessary, but MR angiography is enough nowadays. Management, analgesia, antihypertensive, and nimodipine plays a very important role to control vasospasm, which affects about 25% of the patient with subarachnoid hemorrhage in 5 to 14 days post-stroke and surgery. Complications: rebleeding, vasospasm, hydrocephalus, and hyponatremia. Now we all know about this differential diagnosis or stroke mimics. I am not going into details of that. We have to have a detailed clinical examination and necessary investigation to rule them out. Now the stroke service delivery, according to the World Stroke Organization roadmap, there are 3 tiers of healthcare: the minimal healthcare, essential stroke care services, and advanced stroke care services. Advanced stroke care services should include everything necessary for round-the-clock, means 24 hours service available for hyperacute stroke management. Evaluation of stroke and TIA. It should start at pre-hospital according to the World Stroke Organization, every single member of the public should be aware of first, and they should act fast when a stroke is suspected for urgent medical evaluation. The next stage is assessment of the patient in the emergency room, which is called Rozier scoring. If the score is 1 or more, then the patient should trigger the stroke pathway. And the stroke unit concept, it came about over 2 decades ago, so that's the norm of the day across the globe. I am not talking about that. That actually reduced more than 20% mortality, morbidity. So that's the norm. So assessment in the stroke unit is thorough assessment is the cornerstone of evaluation to determine if the symptoms are due to stroke, to localize the site of the brain lesion, to establish the type of stroke, whether ischemic or hemorrhagic, and ascertain the likely cause. The use of a stroke rating scale, preferably National Institute of Health stroke scale, is recommended to classify to mild, moderate, and severe stroke. Hospitalization is recommended in all acute stroke cases within 7 days or progressive stroke, and TIA with high-risk TIA with ABCD2 score of more than equal to 4 or more than 1 TIA within 7 days. We all know about the ABCD2 scoring system. So risk of stroke after TIA, all the high-risk cases, if you see here, this is an ABCD2 score 4 or more, then they have a 5% risk of stroke within 2 days, 7% risk within 7 days, 11% stroke within 90 days. The modified Rankin scale, this is a very important disability scoring scale. If you see here, the moderate disability, which means the patient requires some help for the ADLs, but still able to walk without assistance. They are independent. That's the important one. This is considered as a favorable functional outcome of an intervention. National Institute of Health stroke scale, total score is 42. If the score is less than 6, that is minor stroke. If it is 6 to 13, it's moderate. And if it is more than 13, it is severe stroke. This CT scan shows a large hypotenuse area in the left middle cerebral artery territory. This is the total anterior circulation infarct. This one shows the black dots deep-seated. They are the lacunar infarcts. And this shows the hematoma in the left middle cerebral artery. This is a primary intracerebral hemorrhage. Now, management of stroke and TIA, it has got 4 distinct steps. First is the immediate management, second, hyperacute management, third, acute management, and fourth, the post-acute management. Immediate management should start within minutes to hours. Is the purpose is to stabilize the patient and confirm the diagnosis, and start antiplatelet, that is aspirin or clopidogrel 300 milligram once daily for 2 weeks if it is ischemic stroke without any other contraindication. Hyperacute stroke management should start within hours to days to prevent brain damage by establishing reperfusion. There are thrombolytic therapy, endovascular thrombectomy, decompressive hemicraniectomy, and surgery for subarachnoid hemorrhage and PICH. Management of stroke and TIA, acute one should be done within days to weeks to prevent complications for best recovery. Dysphagia screening and nutritional support should be started within 24 hours. Prophylaxis for venous thromboembolism, prevention of decubitus ulcers and falls, treating incontinence, urinary retention, constipation, treating underlying comorbidities like hypertension or dyslipidemia. Ischemic stroke patients with dyslipidemia should started on statin within 24 hours, 40 to 80 milligram according to different local guidelines. The treatment of delirium is important. Physiotherapy and speech therapy should be started within 72 hours. Arrange for further necessary investigations like echo, carotid, and CT, MR angiography. Post-acute management, it should be done within weeks to months to maximize independence and maximize the secondary stroke prevention through ongoing mobilization and rehabilitation, optimizing secondary prevention measures for hypertension, diabetes, dyslipidemia, and so on. Carotid endarterectomy, aneurysmectomy, and resection of AVM it can be done. Lifestyle modification measures should be implemented, and advices on driving, air travel, and medical insurance should be done before discharge from hospitals. The new dawn of stroke care, that is hyperacute stroke care, started since 1995 with thrombolytic dialysis therapy, then endovascular thrombectomy, and decompressive hemicraniectomy. Since the publication of the NINDS trial, the first positive fibrinolytic trial in 1995, it opened up the new horizon of stroke care, and it revealed that more than 30% reduction in morbidity. Then subsequently, a series of trials were published, and they formed the basis of this modern-day thrombolytic therapy. They recommended in ischemic stroke within 4.5 hours of stroke onset. The time period can be increased from 4.5 to 24 hours based on the CT perfusion scan findings. If it shows significant perfusion mismatch and an absence of severe or extensive CT hypodensity, they can be extended. Patient up to 90 years of age and NIH score should be less than 25. Alteplase or tenecteplase both are used, but tenecteplase are giving more favorable results in the recent trials. That should be given as a single IV bolus over 5 seconds, 0.25 milligram per kg. Maximum 25 milligram. The benefits, more than 30% reduction of morbidity, a risk of intracerebral hemorrhage is 6 to 7%. Then after the publication of after the presentation of Mr. Clean trial in the World Stroke Congress in Budapest in 2014, that opened up widened the horizon of further hyperacute stroke care. And subsequently, there were several, in the next year, 2015, 6 trials were published, and subsequently several trials. I don't have time to go through them. I'm just mentioning the names. So endovascular thrombectomy, it is recommended in ischemic stroke with large vessel occlusion within 6 hours of stroke onset. The time frame can be increased up to 24 hours with the help of the CT perfusion imaging. The patient selection, initial trials had 70 years upper age limit, but subsequent trials didn't have any upper age limit, but the treatment should be started within 6 hours. There was significant higher rate of functional independence at 90 days. There was no difference in mortality or intracerebral hemorrhage. And 80 plus year patients had at least as much benefit as the younger ones. So they did better actually in some of the trials. The drawback is endovascular thrombectomy is very resource intensive.
Sir,
now
running short of time.
Just couple of minutes, 1 or 2 minutes. Yeah. So now decompressive hemicraniectomy recommended in patient with malignant MCA territory infarct within 48 hours of stroke onset. The last Destiny trial increased the age up to 82 years. So it is a patient aged under 82, severe neurological deficit, NIHSS score more than 15, CT showing an infarct of 50% or more of MCA territory or the infarct volume more than 145 centimeter cube. Benefit, there was significant increase in survival from 29 to 78%. Number needed to treat to save one life was only 2, and number needed to treat one patient with to survive with a modified Rankin score of less than equal to 3 is only 4. Now coming to hypertension and stroke. Numerous trials globally has been done on this topic, and there are several guidelines: American, Canadian, Australian, European, Indian, British. So, the gist of these guidelines actually suggest that non-hypertensive or antihypertensive therapy should continue their treatment. Secondly, in the setting of cerebral infarction, only newly diagnosed severe hypertension should be treated within a day or 2. So that means if the blood pressure is newly diagnosed and more than 180/10, that should be reduced to at least moderate range over a day or 2. In the setting of intracerebral hemorrhage or subarachnoid hemorrhage, this should be, all guidelines suggest that this should be reduced within an hour or 2 to less than 140/90, and the systolic blood pressure should remain above 110. Hypertension should be treated urgently within minutes. In the cases of hypertensive encephalopathy, aortic or carotid dissection, or acute left ventricular failure in the setting of stroke. Anticoagulation therapy necessary in many various scenarios, and nowadays the oral anticoagulation coagulative therapy is the NOAC or DOAC. What we are using, the dabigatran, Apixaban and rivaroxaban, this sort of thing, not warfarin. In case of atrial fibrillation, the initial 2 weeks, they have aspirin or clopidogrel for initial 2 weeks, followed by anticoagulation therapy. Patient with ischemic stroke and prosthetic heart valve who are already on anticoagulant, the anticoagulant should be stopped for a week and replaced by antiplatelets for a week. Then they should be restarted with anticoagulant. DVT and PE with ischemic stroke, the anticoagulant should be the therapy of choice. DVT or PE with hemorrhagic stroke, if possible, a caval filter should be fitted and subsequently oral anticoagulant. Acute venous stroke.
You're exceeding the time.
Yeah, so okay, just a few seconds. Now, feature of stroke care. As you see that despite the outstanding improvement in stroke care over last 30 years, the most of the stroke survivors are left with severe disability. So something is lacking. So we need trials to address these issues. So the key clinical questions: adjuvant thrombolytics. So far, trials with aspirin, heparin, eftifibatide, and argatroban were negative results. The increased risk of hemorrhage and death. So new novel antiplatelets, others are under investigation. Improving microvascular reperfusion with intraarterial newer fibrinolytics and nanopeptide-based drug delivery system are under evaluation. Cytoprotection with nerinetide showed some initial promising results. Neuroprotective agents like metformin, uric acid, pyretinol, or commonly known as encefabol, viticoline, etc., showed some positive functional outcome with initial small trials, and similar results with stem cell therapy as well. So now just last slide, the primary prevention of stroke. So this should be at an individual strategy, and there should be population-wide strategy. Individual strategy: healthy lifestyle measures, regular screening for vascular risk factors, and adequate treatment for underlying high-risk vascular risk factors. Population-wide strategy should start with the healthy lifestyle, regular stroke awareness, affordable medications, affordable food and physical activity facilities, reducing inequalities and poverty, and reducing the intake of tobacco, alcohol, salt, sugar, and trans fats. So these are some of the references I used for this presentation. Now, thank you. Any question?
Thank you, Chinmoy, sir, for a very comprehensive take on a very vast topic. Thank you, sir. because of the paucity of time, we won't be having any question and answer sessions. We can take the questions from the floor later. Thank you, sir, for a very comprehensive session. Thanks a lot.
Thank you very much.
We thank the GSI organizing committee for giving us an opportunity to share this important session. Thank you.
Thank you, sir. Thank you for the enlightening session.